So let's start the topic adenoidectomy. I am teaching you the treatment of adenoid hypertrophy. Okay, we have two treatment: conservative, surgical. Conservative is done when the symptoms are mild, and surgical is done when the symptoms are severe. So currently I am teaching you the treatment when the symptoms are severe. We are doing the surgery, that is adenoidectomy. So adenoidectomy, if it is coming as a long question in your exam, you have to frame your answer under these headings. You can see introduction, indication, contraindication, anesthesia, position, steps of operation, endoscopic adenoidectomy, post-op care, and complication. One by one we will see. First of all, introduction. What is adenoidectomy? It is surgical removal of the adenoids with or without tonsillectomy. So either only adenoids are removed, or along with adenoids, tonsils are also removed. If both are done together, so first adenoids have to be removed. Then we have to do nasopharynx packing, and then we have to begin the tonsillectomy. So this is a sequence if both are done. Okay. Now tonsillectomy I'm going to teach you in the next episode in tonsillitis. You can watch that episode for the details of the surgery tonsillectomy. Here I am teaching you adenoidectomy. So introduction, adenoidectomy is surgical removal of adenoids. How many indications are there? There are 5 indications. When we have to do the surgery, 5 indications. Number 1, adenoid hypertrophy. The hypertrophy of the adenoid, okay, to such a degree so that the child is snoring. You know, child don't snore. If the child is snoring, or there is a mouth breathing, or there is sleep apnea, or there is speech abnormalities. So because of any, if the adenoids are increased to such a size so that the child is snoring at the time of sleeping, or child is constantly doing mouth breathing, or there is speech abnormalities, so we have to go for the surgery. Or there is recurrent infection. Because of adenoids, there is recurrent sinusitis, recurrent rhinitis, sinusitis, or there is CSOM. You can see there is CSOM, or there is discharge from the ear. You can see discharge, persistent ear discharge, or there is dental malocclusion. I told you now, because of adenoid hypertrophy, the dental crowding occur. So dental malocclusion, because the mouth is open, the child is breathing like this. Look at me. From the mouth. Normally we should not do the respiration from the mouth. Okay, we should do it from the nose. Okay, that's the proper way of respiration. But because of nasal obstruction, the dental occlusion can occur, malocclusion can occur. So these are the 5 indications of doing the surgery. What are the 5 indications of adenoidectomy? Can you tell me the 5 indications of adenoidectomy? Nasal obstruction to such an extent so that the child is snoring, child is constant mouth breather, or sleep apnea, or speech abnormalities, recurrent infection, rhinitis, sinusitis, or there is perfo in the tympanic membrane, or constant discharge is there, or dental malocclusion. So learn the 5 indications of adenoidectomy. So there are 5 indications. They should be at the tip of your tongue for your vivas. The 5 indications of adenoidectomy. Now learn contraindication. There are 3 contraindications. They should also be at the tip of your tongue. Don't do it if the child is having cleft palate. Cleft palate, don't do it. Don't do it. In case of cleft palate, don't do this surgery. Hemorrhagic diastasis. Chances of bleeding will increase during the surgery. Hemorrhagic diastasis. Any hemorrhagic diastasis like hemophilia, von Willebrand disease, any. And upper respiratory tract infection. At the time of infection, don't plan the surgery. There are high chances of bleeding at the time of surgery. If the child is having pre-existing infection. Okay, so these are the 3 contraindications. You can see cleft palate, hemorrhagic diastasis, or upper respiratory tract infection, acute infection. So learn the 5 indications and 3 contraindications of adenoidectomy. Rather than mugging it up, see the images. These are the 5 indications. Learn the 5 indication. Nasal obstruction severe to such an extent so that the child is snoring, the child is having a speech abnormality, mouth breathing, constant chronic infection, perfo in the tympanic membrane, ear discharge, and dental malocclusion. These are 5 indications. And learn the 3 contraindications. They are in front of you. Cleft palate, hemorrhagic diastasis, and acute respiratory tract infection. So these are the 3 contraindications. Now, in which anesthesia it is done? It is done in GA. It is always done in GA. In children, GA is safe because child don't cooperate in LA. So we have to do this in GA only, general anesthesia, with oral endotracheal tube intubation. You can see the child is in GA, and you can see the oral endotracheal tube intubation. The same you can see here. The child is in GA, and you can see the oral endotracheal tube insertion is there. So this is how we have to do the surgery. What should be the position at the time of surgery? There is a typical position. This is known as rose position. The same position in tonsillectomy also. In adenoidectomy and tonsillectomy, the position is same. What is this rose position? In rose position, the patient lies supine with necks extended. The neck is extended. Can you see? The neck is extended like this. See my neck. The neck is extended like this. How to extend the neck? Keep a pillow under the shoulder. Keep a pillow under the shoulder to extend the neck. And head is supported with a ring. The head is supported. The head is kept on a ring like pillow. This is how we are doing hyperextension. Okay, and excessive hyperextension should be avoided, but it should be extension, not hyperextension. So this position is known as rose position, in which the neck is extended, not hyperextended. You have to avoid hyperextension. The neck should be extended, okay, by keeping a pillow on the shoulder and keeping a ring over the head. Okay, the neck should be extended, keeping a pillow just below the shoulder. See, this position is known as rose position. Learn rose position, you get MCQ on that. Now, what are the steps? There are 4 steps in surgery. I will show you the video also, but have a look on the 4 steps. Quickly, we will see the 4 steps. First of all, we will insert mouth gag. What is the name of the mouth gag we use here? What is the name of that instrument? It can be asked as a spotter in your university exams, in your practicals. It is known as Boyles-Davis mouth gag. Can you see? This is Boyles-Davis mouth gag. Appreciate. It is kept to keep the mouth open. The mouth will be kept open with the help of Boyles-Davis mouth gag. The mouth will be kept open. Okay, so that the nasopharynx can be seen. The nasopharynx can be seen by retraction of the soft palate. Okay, and using a tongue depressor. Can you see? We are using a tongue depressor over here. Appreciate. We are using a tongue depressor over here to see the nasopharynx. We will confirm the diagnosis. We will see the size of the adenoid and we will use a mirror. Can you see? We are using a mirror also over here. So you can see this is the tongue depressor over here and this is the mirror. This is the mirror. I will show you in the video also. This is the mirror. So to see the exact size of the adenoid. Okay, because it is present posteriorly in the nasopharynx. It cannot be seen directly. In the mirror, we will see the size. In the mirror. So what instruments are used in this step number 1? First of all, a retractor. Okay, what is the name of this retractor or mouth gag? It is Boyles-Davis mouth gag. Appreciate it. After that, a tongue depressor. Okay, and after that, a mirror. Okay, so this is how we are examining it. Now we will do the curettage. We will do the curate with the help of an instrument, adenoid curate with the guard. Can you see? This is adenoid curate with a guard. Okay, we will insert it in the nasopharynx and we will push the curate back and flex it head. You can see this is adenoid curate. Now we will do the removal by doing sweeping movement. We will do the movement by doing sweeping movement, gradual sweeping movement. We have to take care. Adenoids are very close to Eustachian tube opening in the lateral wall of the nasopharynx. You know the anatomy. We have to take care that opening of the Eustachian tube should not be injured during the surgery. This is how we are doing the sweeping movement. Okay, this is how the adenoid, the hypertrophied adenoid is taken out. Okay, hypertrophied adenoid is taken out. It may be in multiple pieces. Okay, and finally the electrocoagulation is done to control the bleeding. To control the bleeding, we are using the cautery to control the bleeding. Okay, and packing the area temporarily. We can put a postnasal pack to, control the bleeding temporarily. Okay, these are the steps of the surgery. Sometime nowadays it is done endoscopically. There is more precise removal. Okay, we don't have to put the mirror. Endoscopically, we directly put the endoscope and the instrument inside. You can see this is how endoscopically we are doing. I will show you a video. Have a look. I will switch on the video. You can see this is how. Appreciate the rose position. Appreciate the mouth is opened with the help of mouth gag. And appreciate how the adenoid is removed by sweeping movement of the adenoid cautery. See again. You can see this is rose position. The neck is extended. You can appreciate the person is in general anesthesia. We are reaching the adenoid. This is adenoid. Appreciate this. We have to remove it. Adenoid hypertrophy. So we are reaching and with the help of cauteries in sweeping movements, we are removing it. Let me show you one more video. Okay, you can appreciate it. You can appreciate this is the child. Appreciate this is the pharynx. Appreciate the nasopharynx. Appreciate the adenoid. Appreciate the size of the healthy adenoid. And appreciate once it become inflamed, how it is increasing in size. It is increasing in size, one become inflamed. This is adenoid hypertrophy. Now we are doing the surgery. So we are using the Davis. Appreciate the Davis mouth gag. We are going inside. You can see we are using the cautery. We are using the mirror. Appreciate the mirror. Okay, and this is how with the cautery, with a step by step, we are removing it. Okay, I hope you got it. Now, what is the post-op care? You know the 4 steps of the surgery. Now, what is the post-op care? Post-op care, mein, there are 5 things you have to take care. Being a surgeon, being a ENT specialist, you have to take care of 5 things after the surgery: immediate general care, diet, oral hygiene, analgesics, and antibiotics. One by one, we will take immediate general care. The patient is kept in recovery position or coma position. This position is known as coma position. After GA, all the patients are kept in this position. This is known as recovery position or coma position. The patient is on the side way. Okay. The patient knees touch the body. Okay. You can see knees stops body from rolling on the stomach. Okay. So you have to keep the patient sideways. Okay, and the mouth should be open. The mouth should be open to clear the airway. So this position patient has to be kept. Patient has to be kept in this position. Observation for the bleeding. Is the bleeding from the nose or mouth is taking place, and look for the vitals. Pulse, respiration, BP, look for the vitals. Then take care of the diet. Once the patient become conscious, start with liquid. Then give semi-solid, dalia, khichdi, then give semi-solid. Okay, and then give solid food gradually. Ice sucking reduce the pain because patient has severe pain. Patient is unable to eat. Avoid spicy food. Avoid hot food. Avoid spicy food. Take care of oral hygiene. Ask the patient to do the gargles. Ask the patient to do the salt water gargles 3 to 4 times a day. Mouth rinsing, kulla and gargles. Rinsing and gargles. Okay, rinsing and gargles has to be done. Analgesics has to be given. Oral paracetamol is sufficient. We can use paracetamol. It can be given before meals. Okay, paracetamol is a good analgesic to cover the pain over here. And antibiotics. Antibiotics has to be given. Okay, analgesics as well as antibiotics. Antibiotics can be given via injection or orally. Injection or orally, they has to be given for 2 weeks. 2 weeks. Okay, orally or IV antibiotics for 2 weeks. So that is the post-op care. General care may keep the patient in coma or recovery position. Diet may first give liquids, then give soft diet. Don't give spices, don't give hot. Okay, then oral hygiene may gargles and rinsing. Gargles and rinsing 3 to 4 times a day with salt water. Analgesics, PCM, paracetamol. Antibiotic may, we give broad spectrum antibiotic, IV or oral. So that is the post-op care. You can appreciate the patient is in coma position, start with the liquid diet and soft diet, do rinsing and gargles, take care of oral hygiene, take analgesics, take antibiotics. Antibiotics for 2 weeks. Analgesic SOS. Okay, this is how we give the post-op care. Finally, the complications of this surgery. What are the complications of adenoidectomy? Can you tell me the complications of adenoidectomy? What are the complications? Most important, there are 5 complications. Most important is hemorrhage, bleeding. Bleeding occurs after the surgery. Okay, it can be immediate post-op period. The bleeding is dark, black, vomitous, dark brown color, and increased pulse rate because of the bleeding. Okay, to prevent this or to treat this, we have to do post-nasal pack. I already taught you post-nasal pack in nose. So how to do, what are the steps of the post-nasal pack, you can see there. Second, injury to the Eustachian tube opening, which is very common in the surgery. You can see close to the adenoids is the Eustachian tube opening. Eustachian tube openings can be injured. You can appreciate the Eustachian tube opening. They are very close to adenoids. This is adenoid. They are very close to adenoids. So during surgery, the surgeon has to take care that during adenoid removal, the Eustachian tube openings are not injured. Okay, avoid hyperextension of the neck in rows. Give rows position. Do extension of the neck, but don't do hyperextension. If hyperextension of the neck is done, so pharyngeal or vertebral muscles can go in the spasm. Okay, pharyngeal or sometimes torticollis happen. After the surgery, the patient have torticollis. You know, the neck stiffness on one side. Torticollis because of spasm of the paraspinal muscle. Because of spasm of the paraspinal muscle. Torticollis, and this is known as Griezel syndrome. Griezel. And nasopharyngeal stenosis can occur later. Excessive use of the cautery. So, where are adenoids? What is the location of the adenoid? Adenoid is present at the junction of roof and posterior wall. So this portion is cauterized. Stenosis can occur in later because of the scarring. So these are the 5 complications of adenoidectomy. Hemorrhage, injury to the Eustachian tube, okay, injury to the pharyngeal muscle or vertebral muscle because of hyperextension of the neck in rose position. Griezel syndrome is torticollis and nasopharyngeal stenosis. Okay, so we are done with adenoidectomy. If it is coming as a long question, you have sufficient material to write in that. And all MCQs can be cracked. You know the introduction, you know the 5 indication, you know the 3 contraindication. The anesthesia is GA. Okay, GA with endotracheal tube. Position is rose position. The steps of operation, you know the 4 steps. Okay, post-op care, you should know the 5 points. And complication, there are 5 complications. Please try to understand with the help of images. Enumeration will be very easy. We are done with the topic adenoid hypertrophy. If it is coming as a long question, you are ready to write. Okay, can we revise it quickly? Adenoid hypertrophy. Introduction. What is adenoid hypertrophy? The adenoid is increased in size. Etiology, there are 4 etiology. It can be physiological, it can be due to allergy, it can be due to infection, or it can be a part of generalized lymphoid hypertrophy. Okay, all the lymph nodes are enlarged. Symptoms, there are 12 symptoms. Okay, 5 of them are nasal, 4 of them are oral, and 3 of them are general. You should learn them, understand them. Diagnosis, you know the way of diagnosing: nasal examination, post-nasal space examination, X-ray we will take, okay, and endoscopy we will do. Treatment में conservative treatment and surgical treatment. Surgical treatment में adenoidectomy, you know all the details of adenoidectomy. So biggest is the treatment, I guess. Biggest is the treatment. We are done with this. Now here, a small disease. One more small disease I am teaching you in this session. We are done with adenoid hypertrophy. Okay, the first disease of this session is done. One more small disease I want to teach you in this episode only. The name of that disease is Thornwald disease. What is Thornwald disease? It is also known as pharyngeal bursitis. You get short note in your university exam on this. Thornwald disease. Okay. So to understand the Thornwald disease, you can't understand Thornwald disease unless and until you understand the anatomy of pharyngeal bursa. First, you have to understand the anatomy because it is pharyngeal bursitis. Thornwald disease is actually pharyngeal bursitis. So you can understand the disease if you understand what is pharyngeal bursa. So what is pharyngeal bursa? I already taught you in anatomy. Here we will revise. Okay, it is related to adenoid only. That's why I'm teaching you here. So first, I will help you in understanding the anatomy of pharyngeal bursa, which is present inside the adenoid. Okay, then we will understand this disease, Thornwald disease. So what is pharyngeal bursa? You tell me what is pharyngeal bursa. Where is adenoid? Where is adenoid present? Adenoid is present in the nasopharynx. Can you see the nasopharynx? This is nasopharynx. In the nasopharynx, at the junction of the roof and posterior wall, we are having the adenoid over here. This is adenoid. Let me zoom it out. Let me zoom it out, this portion. Okay, so here is the adenoid. Can you appreciate this is the same adenoid? Appreciate the adenoid. Appreciate the adenoid. This is adenoid. Let me highlight it. So basically, adenoid is present in 2 portions. I taught you in anatomy also, here and here. And between the 2 portions, there is a recess. And this recess is pharyngeal bursa. Appreciate this gap or recess in the adenoid. Okay, basically this gap is present over here, I am saying. In the adenoid, this is a recess. Appreciate. This is the zoom version of the same. Appreciate. Okay, so you can see there is a recess. Appreciate. Appreciate. So this is complete adenoid. Can you appreciate? This is adenoid. Where is the adenoid? Let's start the adenoid. This is adenoid. Okay, and this is also adenoid. Okay. In the nasopharynx at the junction of the roof and posterior wall. You can see this is roof, this is posterior wall, and there is adenoid. So in the adenoid, I can see a recess. Recess is a epithelial line tract. This is known as nasopharyngeal bursa. It is present anatomically. So basically, it is the nasopharyngeal bursa is present in the midline of the nasopharynx, inside the adenoid mass. It's a recess present in the nasopharynx, in the adenoid mass. What does it represent? It represents the attachment of notochord during embryonic life. The attachment of the notochord during embryonic life. Now, let's start the disease. If you understand what is pharyngeal bursa, understanding the disease is very easy. So disease, I will discuss the Thornwald disease in 4 headings: introduction, symptoms, sign, treatment. So what is the introduction? It is the infection in this bursa. You understand pharyngeal bursa. So infection of pharyngeal bursa is Thornwald disease. Can you see this is pharyngeal bursa? Okay. If pus is accumulated in this bursa, the pus accumulate in this bursa, the pharyngeal bursa. This disease is known as Thornwald disease. So what is Thornwald disease? Thornwald disease is infection of the pharyngeal bursa. What are the symptoms? There are 6 symptoms. One by one we will take. First of all, persistent postnasal discharge. Okay. Why persistent postnasal discharge? Because again, there is obstruction over here. So, you know, the discharge which is formed, it cannot come front. So, postnasal discharge. Persistent postnasal discharge is there. P and D. Persistent postnasal discharge. Nasal obstruction, like adenoids only. The patient have nasal obstruction. Obstruction of the Eustachian tube. The same story. You can see this is Eustachian tube. The tube connecting the middle ear with the nasopharynx. If there is a bursitis over here, nasopharyngeal bursitis, it obstructs the opening of the Eustachian tube. And that's why the person have earache. earache because of otitis media. Okay, the next is occipital headache. The person will have occipital headache, recurrent sore throat, and low-grade fever. So these are the 6 symptoms. Can we revise the symptoms? What I'm teaching you? The name of the disease is Thornwall disease. What are the symptoms? Post-nasal discharge, nasal obstruction, earache, occipital headache, sore throat, and low-grade fever. Okay, so earache, sore throat, occipital headache, fever, and nasal obstruction. What are the signs? If you do the endoscopy, you will see like this. On the endoscopy, you will see a cystic swelling present on the adenoid. In the nasopharynx, there is a cystic swelling, which is fluctuating. Over it, crusting can be present. Over the swelling, the discharge is present, which get dried up. Over the swelling, the discharge is dried up. Okay, and it is looking like a crusting. It is crusting. So that is a signs. So in the sign, we will see a swelling, and over that swelling, we will see the dried up discharge. That's known as crusting. What is the treatment? Give antibiotic. If it resolves with antibiotic, very good. Otherwise, IND. IND is marsupialization. So give antibiotic. If it resolves, very good. But if it is not resolving, do a surgical procedure, that is drain the cyst. Draining the cyst is known as marsupialization. Okay, drain the cyst under aseptic precautions. So either take antibiotic or drain the cyst. That's it. So it was a small topic. Usually you get a short note on that and you get many MCQs on that. You should know what is Thornwall disease. It is infection of the pharyngeal bursa. So you should know what is pharyngeal bursa. Pharyngeal bursa present in the adenoid. It's a recess in the adenoid and it will present the embryonic attachment of the notochord there. Infection in this bursa is Thornwall disease. You know the symptoms, signs, and treatment. That's it. So here in this episode, I taught you 2 big diseases. I taught you adenoid hypertrophy in detail and I taught you Thornwall disease in detail. Thank you so much.